Isakson, you can have the floor.
Great. Thanks so much for having me. It's a pleasure to be here on this beautiful summer afternoon. And so excited to be working on this project with the Westchester Institute for Human Development and a chance to speak to you all today. I am going to share screen. So this is always the moment of truth. I want to share screen one. And start the slideshow. All right, hopefully you can see the slideshow. Okay, great. I'm a relatively informal presenter, so if you guys have questions, put them in the chat box. If I'm not looking at the chat box and totally ignoring you, just come off mute and ask a question. It's okay to interrupt. It's really, I hope to have a conversation, and sometimes that's possible, sometimes it's not, depending on how many people end up as part of the Zoom. So today we're going to talk about building bridges, cross-sector cooperation for developmental promotion in early childhood. And we're going to cover a couple things. I'm going to tell you a little bit about the organization I'm the executive director of, which is Docs for Tots. We're going to talk a little bit about developmental screening in pediatric practice and developmental screening in childcare. And then we'll spend a little time on Help Me Grow as an example of a community-wide systems approach. And then we'll briefly touch on Learn the Signs Act Early and the recent changes to Learn the Signs Act Early. I'm not so good at the old polling and things like that, but I'm curious if you guys that are here can answer yes or no in the chat. Have you guys ever heard of Learn the Signs Act Early materials? And then if yes, do you use them? All right, so we got a couple yeses, so that's great, and that'll help me as we move further on. Now, do I have the right screen to advance the slides? Yes, okay. So Docs for Tots is a nonprofit. We're located on Long Island, but we do work across New York State. And our goal is to really empower all the people and systems that play a role in caring for New York's youngest children. That's parents to practitioners, caregivers to Congress members. And we want to create pathways, tools, and supports to ensure that each child can achieve their fullest potential. We are New York's only pediatrician-led nonprofit taking a whole child approach to early childhood development. And it's a really wraparound approach, building caregiver skills, strengthening systems, and enacting solid policies. We aim to give every child a strong 5-year start on the chance to thrive for a lifetime. There's a couple areas that we work in. One is pediatric practice transformation, where we work directly with different pediatric practices on Long Island, and now actually in 3 different areas of the state to help improve developmental screening practices. We've also done work around maternal depression practices and ACEs screening within the pediatric practice. We do a lot of work with quality childcare support, both in encouraging developmental and social emotional screening as part of regular care within childcare, and providing infant and toddler mental health consultation. And the last thing we do is we run Help Me Grow Long Island, which serves Nassau and Suffolk County. And we are currently heading up a coalition of Help Me Grows that exist across New York State, Long Island, Onondaga, Monroe / Finger Lakes, and Western New York. Those are the 4 that exist in New York. I'm just going to do some level setting here. This is a little bit, I love this slide. I stole it from Paul Dworkin at the Help Me Grow National Center, and he had stolen it from Neil Halfon at the UCLA Center for Healthier Children, Families, and Communities. So there's a saying in early childhood systems, share seamlessly, steal shamelessly. So I'm stealing this slide shamelessly from them. They kind of gave permission years ago. So if we really think about whether children are ready to learn, and that's in quotes because I'm not sure that's the right term, but that's the term that's on the slide. And you look at on the y-axis, and if you look at the x-axis, it's only actually going up to 36 months. It's just going up in the first 3 years of life. And that trajectory is actually a delayed trajectory. And we anticipate, you know, depending on your epidemiological ideas and opinions, somewhere around 2 to 5% of children are going to be known to have delayed development, right? They're the ones that are automatically eligible for early intervention. Maybe they have a genetic or a congenital issue. They're delayed. And then we actually have the vast majority of children. So somewhere around 85%, and they've got the standard deviation lines around that 85%. And that's typically development, right? That's early on a great track. Healthy trajectory is what they call it. And then we've got a track that's in the middle, and that's an at-risk trajectory. And someone can say that maybe that's 10% of the population, maybe that's 15% of the population, maybe that depends on the community that you're working in or the community that you live in. And that's a real opportunity. And a lot of what Dr. Tots does is to think about that at-risk trajectory and how we change the trajectory. So my dad was a mechanical engineer who worked on the Apollo missions, the Mercury missions, the Gemini missions, all of them. And so when I was little, we spent a lot of time putting rockets in bottles and having a bottle rocket and thinking a lot about trajectories. And so we actually know, if you think about that analogy, the way you start off really sets a trajectory, and it takes a lot of energy and a lot more effort to change a trajectory the further off you are from its start point. So that's why these first 3 years are so critical, and it's our opportunity to really work. What are the things that can take an at-risk trajectory and push it down into delayed and disordered trajectory? Socioeconomic disparities, inaccessible health services, domestic violence, child abuse, you name it. These are the regulars. What are the things that can actually take an at-risk trajectory and push it up into a healthy trajectory? Parent education, emotional health and health literacy, protective home environment, a medical home, neighborhood safety and support, quality early care and education. Those boxes could be all kinds of different names. Home visiting is not on there, but probably should be, right? And same with the boxes that push it down. You can fill in your own boxes. But I really like this slide as setting setting the table of where we're having this conversation from and the opportunities that we have to really shift developmental trajectories. Okay, so here's my second analogy. I love analogies, and I'm a little bit of a storyteller, so bear with me. What is this? It's a quilt. Is it a fancy quilt? No, it's by some family that needed to stay warm and stitched materials that they had handy together, and maybe they washed it and it's hanging on the back of a fence, right, on a beautiful sunny day like today. These are also quilts, right? They're beautiful. They're actually in a museum. They're probably worth millions of dollars. And this quilt, I feel really old when I put this picture up. Does anyone remember what these quilts are? It's the AIDS quilts, right? That went around the country, and every family that had lost someone to AIDS developed a quilt in honor of that family member. And it went around the country for years. I don't know if it still does, but my point is, oh, actually, I should also ask, were any of you quilters? Because quilting it tends to be a woman's thing, right? In early childhood and caring for young children. I don't care whether you look at the workforce that is in childcare, or quite frankly, if you look at the workforce that's in pediatrics, they're predominantly women. And and men do quilt, don't get me wrong, but women traditionally, it's been a quilting tradition. And actually, I found this quote from Henry Bellows, who was the U.S. Sanitary Commissioner during the Civil War. And he said of the quilts, so every Northern Union soldier, they didn't give them blankets. The family had to create a quilt and send them with them. So many patches, each sewn of its own color or stuff, which were tacked and basted and then sewed and stitched by women's hands, wet often with women's tears and woven into the women's prayers. And in the aftermath of World War II, millions of quilts were sent to Europe because the factories were all burned out. They couldn't actually make textiles, and people just kept on sending quilts to keep the refugees warm, to keep the Holocaust survivors warm. When you think about antique baby quilts, mortality rate for an infant was 50% or more. right? Yet moms and grandmas and aunts sat down and made beautiful antique quilts in anticipation of the birth of a child. And we went through the AIDS quilt. So why am I spending so much time on this? Because quilts are family and community focused. There's something that's done in the home, yet they have national implications and national impact. And right now, when I have a vision for early childhood in the community, how we all work together, right now we expect families to stitch together the programs that we offer them, to stitch together childcare and early intervention if they're enrolled in early intervention. If they're part of, if they're part of CPSC, if they have an OPUS case, we expect them to stitch together the different services. The pediatrician and the early care and education, we don't work together. We expect the families to have us work together. And my vision is that some days for us to take that responsibility away from the family, the expectation that they have to stitch all these programs together, and instead we as a community stitch those things together so it can help the family be warm and comfort their children. So that's my other analogy. First, you got the rockets, and the second are the quilts. So everything, you can tune out if you want now, because I think that those two stories really tell everything else that we're going to get to. I'm going to spend a few minutes on practice transformation. So how do we get physicians, childcare providers, you name it, more engaged in child development and really changing their practices? We're going to talk for a minute about developmental screening. So I just want to be clear that when I mean screening, I mean the use of a validated tool, and surveillance is something that you do with, questionnaires, a checklist, that sort of thing. So 15% of children have a developmental delay. They can often be ameliorated if addressed early, therefore getting kids on the right track. Screening can catch 70–80% of delays. Screening is not common practice in New York. We rank 49th out of 51 because they count Washington, D.C. as its own state. As a result, many children with delays are going undetected and arriving at school behind their peers. So standardized developmental screening has been recommended by the American Academy of Pediatrics and Well Child Care since about 2009. I think the first article came out in 2006, but it was a little wishy-washy, at 9, 18, and 24 or 30 months. So 3 times before you're 3. Those ages are hard to remember, so I'm always like 3 standardized screenings by the time you turn 3 years. And that's in addition to any specific autism screening that you might be doing, whether it's an MCHAT or another screen. And also in addition to surveillance. So at every visit that you're seeing a child, you're talking to the parent about development, their concerns, eliciting those things, but also administering a valid tool. There's a lot of discussion about what tool is best and how to use a tool. I am tool agnostic is what I say. As long as you're using a valid tool, that's better than not using any. Parent completed ones are most common and fit best into regular practice. I kind of know that people really aren't doing, we're gonna offer those of you that do primary care, if there's anyone on the phone, a survey at the end. So I'm giving away an answer right now. I actually know whether a provider is doing screening or not with a standardized tool, because if I do the checklist and they come back and they tell me that they're doing the Denver, I'm like, they're not doing screening. It's not practical to do an entire Denver developmental screen in a well child visit. They also don't update it anymore. It's kind of been abandoned, and that they don't keep up the psychometrics, but it's a good clean. Yeah, there's a couple good, the SWIC, the ASQ, the PEDS, there's others, but parent completed, parent reported is usually the standard of care right now. Developmental screening in pediatric practice ain't easy, right? If you tried to do everything that was recommended to you as a pediatrician on every well child visit, it would take a day and a half with each parent. Let's just be honest, right? There's a great pediatrician that does a study where he has measured the weight of the Bright Futures books over time. And Bright Futures is the guidelines of what you're supposed to cover. And it just keeps on getting heavier and heavier and bigger. So they just keep on adding things that you should do. But developmental screening and the developmental child is really within the pediatric wheelhouse. It can't honestly be done effective and efficiently just by the pediatrician. It has to be a team approach. This is a run chart of some work that we've done with continuous quality improvement in federally qualified community health centers. This is just one of them. And they did great. Like, look at that first month from March to February, they actually did 100% of the screens. And look at the second month, they're down to 70, right? Because whenever you have initiatives, you have a new grant, you've got this money to do it, you do great in the beginning. It's sustaining the change that is so hard. So you can see over the course of the year, they went up and down. You can see one of their bad months was August. Oh, I wonder why. I can tell you why. The medical assistant that actually is the one that held this entire thing together at the clinic went on vacation for 3 weeks to their home country, right? And it all fell off. And you see this time and time ago. So again, so even if you're doing developmental screening, it takes ongoing attention to detail and effort to keep it as good as you can get to really catch all those kids that come in for the well child visits. Okay. Developmental screening should be happening at the pediatrics office. It can also happen anywhere else in the community. Here at Dr. Tots, we've been really working with childcare using a learning collaborative approach over the past almost 3 years. We've done 5 cohorts in partnership with the Child Care Council of Nassau and Suffolk, where we've trained over 35 childcare settings. Some of their large childcare centers, and some of them are small family providers, using a continuous quality improvement method to get them to do ASQ3 and ASQ3SE screenings. The best practice is when the teacher does the screening, they've known the kid for 3 or 4 months, and they screen, and they have the parent screen the child, and they have this lovely conversation about, how do you see this child's development? How do you see this child's development? That being said, it's just as hard to do this in childcare, if not harder than in pediatrics offices, because it's under reimbursed setting, it's understaffed, it's gone through a lot of challenges during the pandemic. But the practices, the settings that do implement it find it very useful. And it's a way to really start having a conversation with parents about developmental concerns. Okay. I'm going to stop and take a breather. Any questions on those things so far? Okay. So I'm going to move on to the next thing, which is Help Me Grow Long Island. Help Me Grow is a national model of systems building around early childhood and young children. As I mentioned, there's 4 affiliates, there's 4 systems in New York State. We happen to run the one on Long Island. We officially launched in January 2020. It's not a program or a nonprofit, right? It's actually a systems initiative. We like it to be a real collaboration. It's hard to get people constantly collaborating, but it is possible. And it's a real partnership to see how we can stitch those pieces of quilts together, right? How we as a community can make things connected. It's free to use for any families and providers. And we offer free developmental screening and social emotional screening in the ASQ online to any parent on Long Island through our website. It has 4 components. One is a centralized access point where any parent on Long Island can call and get a screen. They can also get coordinated services to help them access EI, preschool special education, food, diapers, whatever their need are. We have 2, sometimes 3, but I'm trying to hire someone, and I know that's hard for everyone right now. 3 family resource specialists that do that work and link. We don't provide any direct service other than offer a screen, because what we want to do is build up the existing services. You know, in New York State, we often have a plethora of programs. What we don't necessarily have is great ways to connect families to those programs. So that's what Help Me Grow does. It tries to connect things. We do continuous family and community outreach to find out what programs are available, what their criteria are, and we keep a large database of everything that's available on Long Island for kids under 5. We do data collection and analysis, which we'll get to, and we work a lot with pediatric providers as they are pre-pandemic. They were about 60 to 70% of our referral base to our centralized access point. During the pandemic, that bottomed out at like 20% of our referrals because kids were not going to well child visits, and post-pandemic, we're about 50% now. So I'll go into the numbers in a second. The other thing about Help Me Grow is it's all about cooperation. Right? It's about getting, it's not these separate cogs, but it's the space between the cogs of the wheel. It's the grease. It's making the system frictionless for families. And right now it's not. Right now there's a lot of friction in the system for a family. I love the last picture. So, you know, like any system, and when we first started, we started with chaos. We started with, well, this one place, the Child Care Council of Nassau, is funded by OCSF to do this, and these are our outcomes. These people are funded to do that, and those are their outcomes, right? So everybody's has their own deliverables, has their own outcomes. But how can we as a community come together and start to align those arrows and all be facing the same direction, understanding what each program, each nonprofit, each thing that we can offer, how does that align in one goal? And as part of our leadership team meeting, we have representatives of both county health departments, including their EI departments. We have representatives from over 60 nonprofits across Long Island that are part of our leadership team that work together to try to build a system for early childhood. Results. Early in the chat, Palumi, who works for me at Docs for Tots, had dropped in a link to a report that we actually published about 2020's data. Our 2021 data is currently, well, it needs to be at the graphic designer by August 1st to be finished. So I don't have 2021 data for you yet, but it's coming soon. And so you're welcome to look at that report as you want. One of the things that we had done in 2018, we did a social network analysis of all the different providers on Long Island that worked with young children. And then we repeated that social network analysis 3 years later and actually found that the trust had significantly increased among all the different people that participated in the social networking survey, as well as interconnectedness. It's hard to interpret pre and post social networking results because like the network changes, right? So, but we're pretty sure that we increased trust and we increased interconnectedness and interdependability. Our family resource specialists take care of about 1,000 families per year, more kids, right? Because people have more than one kid. That is a small drop in the bucket for the population of Long Island, right? Long Island has 3 million people. It's the same size as the state of Connecticut. And we don't ever want to get to the point of serving every child in need in Long Island. We actually want to solve the problems that our family resource specialists are identifying in order to make Help Me Grow Long Island and that one-on-one need not possible. We have a 90% connection rate, which we're very proud of. And right now, we currently have a 50-50 mix. So about 50% of our families come to us with developmental concerns. They're trying to link their kid to early intervention, or they're trying to get access to preschool special education evaluations, and they're having a hard time navigating those systems. Or they come to us with basic needs, meaning that they need diapers, their WIC ran out, they don't know if they're eligible for SNAP, they need formula, all those kinds of stuff. And you might ask, well, what does that have to do with child development? And I don't know how many of you have kids, but I will tell you, if you've ever been at with an 18-month-old or a 12-month-old who has a soggy diaper and you have no new diapers to change that, you are not going to be promoting that child's development. The child's angry, you're angry, everybody's short-tempered. A case of diapers can do a lot to improve that family's outcomes right then in that moment. And what we do for every family that connects to us with basic needs issues, we make sure that they're enrolled in WIC. We make sure that they're enrolled in SNAP if eligible. We make sure that they have long-term connections. So we're making the first introduction to the food bank, but we anticipate that they continue with the food bank. They're not coming back to us time and time again, although some of them need to come back a couple times. Okay, CPSE report. So one of the things that we found on Long Island is that we really struggled on the island trying to get families of color and families that spoke a language other than English hooked up with preschool special education evaluation. So these are kids that kind of missed early intervention. They were 2 years, 10 months when the pediatrician was like, I really think you should have this kid evaluated for speech delay. Or they were 3 years, 3 months that they're like, you're really doing some repetitive behaviors and I'm concerned at the childcare. Let's see if we can get them evaluated through preschool special ed in your school district. That report is also now in the chat. It's the second one, centering the family experience. And what we found, going back to the really detailed data that we collect on each family, is that we found one of the most predictive factors of whether you got your services on time or not was whether you owned your house or not. And then we went back to we didn't randomly select, we selected 10 school districts on Long Island. Long Island has a ton of school districts, it has 125. So we selected 5 high needs school districts and 5 wealthy school districts, and then compared their registration requirements. They're all 10 of them were terrible. If you owned your house, it was really easy to register your child with the school district and then request an evaluation. If you rented your apartment, it was really, really hard to get all the paperwork in order. If you lived in non-traditional housing, meaning you were living in a room of a house without an official lease, it was really hard. And so we've been actually working with our communities across Long Island with the school districts, with actually some assembly members to try to address this. If we had been looking at just one school district, we really wouldn't have seen the problem, but it's because we collect data on these 1,000 cases across multiple school districts that the problem really rose up. And we listened to parents. Parents said that the preschool special education process was a nightmare for them. And we actually had when we explained the process, 50% of our families that are many immigrant, Spanish speaking, or families of color didn't even progress. They said, I can't do that. There's no way I can handle that with everything else in my life. And so they never continued for services. And we saw that every step of the way, we lost further families. Interestingly, of the families that made it through to evaluation, guess how many were eligible for services? 100%. A little of that is that there was a selection bias, right? The people who stayed at it needed it the most. But in general, the return, like the evaluation for eligible versus ineligible for preschool special education is around 50%. 50% of the kids that are evaluated are found not eligible. So to have a 100% hit rate means that we're losing a lot of kids in the process that could be eligible for services that we could hit, that are coming from high risk neighborhoods, high need situations, but they can't navigate the system. So we're working hard to put what we found in that report into practice. It ain't easy. I'll just leave it at that. So on your, feel free to peruse those reports on your own. I can't go into them in too much detail. How am I doing on time? Oh, I'm good. I'm going to take a few minutes to do Learn the Signs Act early, and I didn't get to look through all the comments, but it sounds like at least 5 or 6 use them in training. One person hadn't heard of them, but yes, some people have heard, not used. So what are they? Okay, so I want to talk about Coca-Cola for a minute, right? Or Nike. If I showed a swoosh to you, would you know what that was? Of course you would, right? When it comes to child development, we have 100 different checklists from 100 different people, 100 different ways, and parents get all these different messages, and they're like, whoa. Learn the Signs Act early are really solid materials. Are they perfect? Do they fit exactly what you want to say? Maybe not, but they have been vetted and they have been put through focus groups and they have been designed by marketing people that know far more about marketing than you do. I'm sorry, or at least more than I do. And put together in a way that's great. They've existed for almost, I think, 15 years. It might be 20. I'm sorry, my things are off. And they're really useful. So let's talk about them. Oh, I clicked on the wrong thing again. They're really just about helping parents and other care providers learn the signs of typical development and act early on concerns. The signs of typical development are milestones. It is not an official child development screen. These are more like checklists. They're more about teaching parents and people that care for young children about general normal development. Initially, when they first came out, they're very much focused on autism identification, but in the past 15 years, it's really broadened to just general development. And what do we mean by act early? Like, what are you supposed to do? You're really, and the messaging is clear that they're supposed to talk with their doctor, ask for a screening, get a referral to a specialist, and connect with early intervention. So those are like the end goals. Those are the actions that we want people to do. They're research-based. They aim to improve identification. They're free. They are free for parents and professionals. And the nickname is LTSAE, which is the worst acronym known to mankind, but we're stuck with it. But I actually like to say it out, learn the signs, act early. But when I have to write it in a grant, I use learn the signs, act early. I use the acronym because it takes up less characters. So how are they free? You can order them online through the CDC. You can get them delivered. You can't exactly choose exactly what you want. They'll send you what they have. You can request stuff, but if they don't have it, they might send you alternatives. So it has to do with like what they have in stock. Don't tell anyone, but what we used to do in Long Island when we needed more materials is everyone would order them to their home address because they don't like to keep sending it to the same address. Don't tell the CDC I'm saying this. And so we'd actually have like more materials, and that's how we'd get more free materials. They are available in English and Spanish. You can print them yourselves. Actually, if you want to print them yourselves and like pay a printer to do it, there's a really easy way to put your own logo on it. So if you have extra money sitting around for printing, that's a possibility. They can be adapted, translated, customized to help health professionals. They're available so all the materials are available in English and Spanish. Some of the materials like the milestone checklists are also available in things like Chinese, Urdu, Korean, Russian. So some of the more general are available in multiple languages. The booklets and the more complicated stuff tend to just be available in English and Spanish. I was working with a pediatrician on a project last year in Long Island City, and she had a large Bangladeshi population, and it was not available for her Bangladeshi families. So she actually had it translated in part, and then actually laid them out themselves and printed them out themselves. So you can do that. The CDC does not have any copyright on any of this stuff. You can manipulate them as you like. That's an example of the milestone checklist for domains, and they actually got rid of the developmental flags. Oh, this is an old slide, sorry. And you can distribute them to families at every well child visit. We now have childcare providers all across the state distributing them. We have some community health workers distributing them in 4 different pilot sites of New York State's First 1,000 Days campaign. And that's what it looks like. You may have heard, because it kind of made the news a little bit, that the revisions were published in February 2022. And it became a little bit of a political thing because people thought, well, maybe they're making the revisions because they don't want to admit how bad kids did during the pandemic. All of the work to do the revisions was done in 2019, and they never published the paper, and they never got it done because the pandemic interrupted. So it's not like the work was done before the pandemic. The deliverable did not happen until 2022 because everything got pushed to the side because the CDC was a little busy doing some other stuff, right? Like a lot of us were during that time period. That being said, is this the only one? Oh yeah. That being said, this is the article that was published in Pediatrics about how they came about revising the milestones. They basically streamlined them. They removed a bunch of them. They did not add any because they found it was a little overburdensome, and they shifted the goalpost a little bit. So what do I mean by shifting the goalpost? The previous milestones were done at a 50th percentile marker. So I'm going to make one up because my brain isn't functioning. So if 50% of the kids walk at 12 months, they said, is your child walking? They felt that what that actually did is created an atmosphere of wait and see, because honestly, if you don't have a 12-month-old that's walking, you can wait and see, right? Only 50% of the kids should be walking by 12 months. So what they've done with the milestones, instead of it being 12 months, it's now moved to 15 months. So if you have a kid that's still not walking at 15 months, that's 75th percentile. Only 25% of the other kids, you know, in a population aren't walking. You should do something. So they tried to push the goalpost a little bit so that when it didn't get chalked off, when a child wasn't making a mark, it made more impetus to do something right there and then and not wait and see. I'm not sure I did that really justice, but that was the goal. It did create a lot of chaos and confusion when it first came out. But I do think it's really solid of why they wanted to do it. And they did take, some people are very upset they took their favorite milestones out. But when you really think about when they removed them from certain age groups, when you really think about parents, you got to streamline information, right? Like you've got to make it doable and easy. So all the materials on the website right now on the Learn the Signs Act Early are updated to the current recommendations. And this is the fancy schmancy academic article if you're interested in reading it to find out more. Okay. Oh, I'm doing really good. So we're going to have lots of time for questions. So I'm hoping that you guys have questions. What are my take-home messages here? Family supports in early childhood are best when they're coordinated, right? Best when this work is done by the supports, not the families, right? We can't constantly think that the families can navigate all these different things. In the first 5 years of life, they're not connected to a school. They're not connected necessarily to a community. You move a lot in your first 5 years of having children, right? Once those kids enter kindergarten, most families don't move unless they have to, right? Developmental screening efforts in New York State have what I call room to improve, both within the pediatric practice and within childcare. Some states require, in their quality rating system for childcare, require that all childcare is to get the highest quality rating administer developmental screens. So it's standard of practice or best practice in some states. In our childcare quality rating system, you get a point for it, but it's not, you know, it's just 1 point. It's not really what pushes you over into a high star childcare. In pediatric practice, we have a lot of room to improve. I think we are better than we were 10 years ago when Dr. Tots really started this work. We worked with 5 federally qualified community health centers that were doing 0 screening. And when they found a child that they thought was delayed, they didn't even refer them directly to early intervention. They referred them directly to the developmental peds for a 6-month waiting list. And we were really able to work with them and make sure they were doing simultaneous referrals. So you refer the child, if you suspect delay, you refer to early intervention. If you do think they need to be seen by a developmental pediatrician, you make that appointment at the same time, right? And you do developmental screening so we can find these kids. So part of the project that Jenna at the Westchester Institute for Human Development and Dr. Tots are working on is we're actually looking for primary care pediatric practices served by the USID that might be interested in getting technical assistance and help and understanding your pediatric screening initiatives that you're doing at your own practice and offering technical assistance and help to figure out how to get you, as I went back to that run chart, how to get you away from being stuck at 70 up to 85, or maybe you're only at 50, can we get you up? Or you know what, maybe you're at 0, and how can we get you starting to screen according to the AAP guidelines? I think what we can do is put a link to a survey in the chat box. I think hopefully Palumi can do that, if not Jenna. And if you are part of a primary pediatric practice, or you know of a primary care pediatric practice that might be interested, you can share this link and they can complete a survey and will help us identify people that might be interested in this initiative. So that's one of my take-home messages. My next take-home messages is systems efforts like Help Me Grow. Now, we chose Help Me Grow because it was an evidence-based thing, and I hate reinventing the wheel. And I was like, we're going to go with something that other people are doing. There are many other systems initiatives that are homegrown, and maybe they're not called Help Me Grow. Actually, we work very closely. The Rochester Help Me Grow affiliate actually started off as something else. They decided to become a Help Me Grow affiliate, but for 15 years, they were Rochester Grow, doing their own screening initiative, doing it their own way. So it doesn't have to be a name brand. It can be whatever your community finds fits with what you're doing. But it is really important to build the integration and access so that families really have equitable access to the services that are available to us across New York State. And my last take-home message is, again, don't reinvent the wheel. If you have a checklist that was built by someone else, if you built your own checklist, if you're talking about development, not using Learn the Signs Act early materials, throw out what you're using and order the CDC's materials. I say that a little bit bossy, but they're really well done. They're standardized. They've been tested. They've been marketing, they've had expert marketers put them together. So please consider using them in your practice. There is one other thing I'll mention with the Learn the Signs Act Early that we've had great success, actually across New York State in a bunch of different initiatives. They actually have a Learn the Signs Act Early app, which helps you track your child's progress. I don't know how many of you have experience with the different developmental apps that are out there. There's Sparkle and there's Room and there's all these different things. I like them all, but for many of our families, simple is better. Actually, even for me, I signed up for Vroom one time and it sent me so many messages. I use my dogs, my kids are grown, they're in college, but I use my dog's birthday and I kind of got the messages and I'm going, I had to take away notifications and like finally delete it because it also took up a lot of data. What's nice about the Learn the Signs Act Early is it's not that much data and it's not that many notifications and pushes. So that's what I have for you. Those are my 4 take home. Family supports matter. It's our job, not their job. Developmental screening efforts are important. Think about not only what your own personal silo, for lack of a better word, is doing with developmental screening, but what the whole community is doing around developmental screening. Think about the system and how the families are experiencing the system, and think about using common messaging across the state and across your community. And Learn the Signs Act Early are great examples. Okay, so that's what I have to say. And we have about 15 minutes left. And I know Trisha wants to do a poll at the very end, but why don't we open it up for some questions? You're welcome to put them in the, I'm going to stop sharing if I can remember how to do that. You're welcome to put them in the chat.